I will be I'll be giving you guys a cardiology question review session. I gave the session last year and I got some good feedback off of it, so I kind of removed a few questions, added a few questions, tried to, hit some topics I didn't hit last year. Um, the way that this session is gonna go is I'm going to give you a question. I'll let you guys read it and give me your answers. And then afterwards, I'm going to kind of go through the question, give you guys the right answer. And then for some of the more important topics, I put like a brief summary slide afterwards. I found that this method kind of works well and kind of helps you, revisit and relearn things that you might have forgotten about important topics. So without further ado, I think we can start. For the first question, after you guys go through it, the first thing I want to do is I want to show you guys how to kind of approach these questions, because in general, I know that on the university exams, not all of them are that long. Some of them are like one-liners, but if anybody is going to take the USMLE or any like bigger exams, then they often come as large, paragraph type questions. So it's important to know how to go through these types of questions, what to look for, what would be like a red herring, something that you don't want to look for. So that's what I'm going to kind of go through as well. And yeah, hopefully you guys benefit from this. So this is the first question. I'll let you guys go through it first. Give me your answers, and then I'll go through it with you guys. Sorry. Oh. Okay. So some people are giving their answers in the chat. Okay. So let's go through the question together. Now, in general, when I see a question that's like kind of long, the first thing I do, that I recommend other people do, is to kind of see first, you want to see what are they asking. Okay. The first thing I do is I go straight to the last line. I see what are they asking. Here they're asking which of the following ECG findings is most likely to be seen in this patient. Now, immediately, your mind is going to ECG. You're kind of thinking about, okay, what are the different types of ECG problems I know? I know AFib, I know VFib, I know, et cetera, et cetera. Okay, after that, you want to go to the patient. Who is he? 56-year-old man. Why is he here? What's his chief complaint? He's coming here with chest palpitations, okay? Now, in general, when it comes to palpitations, you kind of want to find out what do they mean by palpitations, because it's such a vague term. Palpitations, not everyone describes it the same ways, but here it tells you very simply he feels like his heartbeat is fast and very irregular. Okay. Now they mention here no chest pain, no shortness of breath, no dizziness. These are basically things to tell you that it's not like a STEMI, or it's basically trying to tell you that it's not another diagnosis. Now here they give you irregular rhythm. This tells you immediately what the disease is, right? Most of you said in the chat, atrial fibrillation is what this guy has. And with atrial fibrillation comes absent P waves. Now, with irregular rhythm alone, you should be able to answer this question. But it tells you here as well that he recently consumed a large amount of alcohol, which can precipitate atrial fibrillation. Now, if we just go to this slide over here, as you mentioned over here, AFib, most common cardiac arrhythmia, okay? What we see on ECG, we see absent P waves, we see irregular rhythm, and we see oftentimes narrow QRS complexes. Okay, risk factors include hypertension and coronary artery disease, and over here may be precipitated by alcohol consumption, which is what our patient had over here. Okay, one major complication that you should be aware of is that with AFib, with like the turbulence inside the heart, what happens is that it could form emboli, form thrombuses, and those thrombuses can go and get lodged into the brain, can cause stroke. Okay, this is very important to note. Okay, other causes of an irregular heartbeat, but doesn't have it has a regularly irregular rhythm, is a second degree AV block. So it's important not to get confused between these two. With AFib, it's irregularly irregular. Okay. I'm not sure how important it is for you guys to know, but just in case, you should know that oftentimes you use class 2 or class 4 antiarrhythmics, or you can use cardioversion to manage these patients. But while doing cardioversion, you should give them anticoagulants because of the same reason as earlier. You want to worry about these thromboemboli, which can cause stroke, right? We can see a picture here. It's very important. My session doesn't really go over like the ECG abnormalities, but it's very important that you know all the ECG abnormalities, especially the ones that come in the clinical lectures, because they'll bring those pictures. Even in OSCE, they'll just bring a picture and they'll say, okay, which one is this? And then you have to type it out. Okay. So be aware of what they look like, how to identify them, because guaranteed to come. And if you know them, then it's guaranteed free marks. Okay. Does anybody have any questions? Okay, we'll move on to the next question. Okay, some people are trying to answer in the chat, so we'll go over the question. Okay. Now I'm just gonna go over the question normally, just so that we can go through this a bit faster. 55-year-old man comes in with hypertension, hyperlipidemia, type 2 diabetes, and asthma. And he comes with 2-month history of dry intermittent hacking cough. Okay. He has no fever, no chest pain, no shortness of breath. He does not smoke cigarettes. Current medications include simvastatin, metformin, albuterol, and ramipril. Okay. They give you his temperature and his pulse, and they tell you he's hypertensive. Which of the following is the most appropriate initial action by this physician? Okay. So by giving you all these like negative symptoms, like things that he doesn't have, they're basically telling you that it's not a pulmonary disease. Okay. So they give you his medications, and we know that out of all these medications, one of them does cause dry cough, which is ACE inhibitors, ramipril. Okay. So you guys are saying it in the chat. It's correct. The answer here would be C. So we stop the ACE inhibitor and we start the ARB because ARBs do not cause dry cough. Does anyone know why ACE inhibitors cause dry cough? Exactly. Because the angiotensin enzyme actually degrades bradykinin. And so by administering an ACE inhibitor, you stop that angiotensin 2 enzyme from being formed. And so you actually, by default, increase the amount of bradykinin, which causes bronchoconstriction in the dry cough. I mean, it's not too difficult of a topic, but I feel like it's very important. ACE inhibitor is used for hypertension. It's used for heart failure, proteinuria, and diabetic nephropathy. Okay, so it came in our exam. It comes all the time where they say diabetic with hypertension. What's the best medication to give? It's ACE inhibitors because it helps with the diabetic nephropathy and it helps with the hypertension. Okay. Also, this came as a SAQ. The ACE inhibitors prevent heart remodeling. I believe you take in LGD or something. We didn't learn about it until that LGD, and then it came as SAQ, so it's important to know it. Adverse effects: dry cough, angioedema. Both of these are due to the increased bradykinin, hyperkalemia, and hypotension. Additionally, very important to note that it is contraindicated in pregnancy because it's teratogenic. It causes illegal hydramnios. It basically messes up with the kidneys of the baby, which produces the amniotic fluid, and so that's why it can have very, very devastating effects on the baby. Does anybody have any questions on this? There's a question I'm going to get to at the end of this lecture that's from a previous batch that kind of deals with how it might be asked in your exam. But if nobody has any questions about this, we can move on. Okay. Oh yeah, this is the question. So actually, before you guys answer, I'll just go through the question. I got this from a past batch. I don't remember which one. I think 13. 45-year-old male, hypertension, comes to the clinic for his routine checkup. His doctor prescribed 2 antihypertensives to manage his blood pressure. His recent workup reveals respiratory rate at 17, blood pressure 15, heart rate of 80. Electrolyte workup shows the following: sodium 138, which is normal; potassium of 6, which is high; calcium of 9, which is normal; bicarb of 32, which is a bit high. Which of the following drugs is associated with this patient's condition? Now, the answer here is B, ACE inhibitors. But I want you guys to know that ARBs also cause hyperkalemia. So just because the answer that they want from you is B, and if this came on your exam, I want you to choose B. But just know that ARBs also do cause hyperkalemia. So it's not that good of a question in my opinion. But the better answer, and because this happens quite a lot with for some reason the pharmacology doctors, they do this where they'll have multiple quote unquote right answers, or one may be slightly better than the other, but because one of them was explicitly mentioned in the lecture, or one of them like they focused on more, that's the answer that they want. And so while they might accept 2 answers, and oftentimes they do, it's just safer to choose the one that they want, the one that they harp upon. Okay, A and C are completely wrong. Does anyone have any questions about this? Okay, perfect. Okay, let's go through the question. 54-year-old man comes to the office with episodic burning, substernal chest pain. His pain increases with activity and improves with rest. Okay, so this is kind of giving us angina type vibes. Okay. He has a history of hypertension, hyperlipidemia. He smokes packs cigarettes daily for the past 30 years, which is a risk factor for MI. His blood pressure is 140/85. His pulse is 76. So he's hypertensive. Cardiac auscultation reveals an S4 heart sound. Okay. Lung and abdominal examinations are unremarkable. ECG shows left ventricular hypertrophy. Myocardial perfusion scan shows inducible ischemia of the inferior surface of the heart. Which of the following coronary arteries are most likely occluded? Okay, very simple. Inferior surface of the heart is what's it called? Which artery supplies the inferior surface of the heart? I guess that's what I'm asking. Now we know that the answer here is D, but which artery is it actually? It's a branch of right coronary artery. Yeah, PDA. So in most people, so here it says 90% of people, the PDA comes from the right coronary artery, right? Which is what they say, right dominant, left dominant, is what they're talking about. Okay. And then the inferior portion of the heart is supplied by PDA, sorry. It's important that what's it called? Right versus left dominance, because they might ask a question about it. It's unlikely, but in case they do, it's important to know. Also, the most common artery for MI in general is LAD, which would show an anterior MI. It's important also to know that the right coronary artery supplies the SA and AV node. And so if the right coronary artery is occluded, it could lead to bradyarrhythmia or a heart block. Okay. This there's I'd give like a 75-80% chance you get a question on this. Very simple, not that difficult. Coronary arteries, there are not that many of them. Just know the main ones, know where they supply, what portion of the interventricular septum, what portion of the heart do they supply, and you'll be golden. Okay. Any questions on this? Fairly simple. Okay. I'm just gonna go through this one. 69-year-old man came to the emergency department with sudden onset palpitations and dyspnea. Okay, past medical is significant for hypertension and GERD. Okay, his ECG reveals a heart rate of 120 with an irregular rhythm, narrow QRS complex, and no P waves, which we already said was AFib. Okay, we went over this. Now it's asking here, which of the following physiological factors determines the ventricular contraction rate in this patient? Does anyone know the answer?
Is it A?
No. So here, when we say no P waves, the P wave is essentially the SA node causing the atrium to contract, okay? But if the SA node is gone, then we'll have no P waves. So if the SA node isn't working properly, then we get the absence of P waves, right? Which happens in AFib. Now, if the SA node isn't working, the next one after that controls the rhythm of the heart is the AV node, okay? So here, what happens is, the answer here is B, sorry. So what happens is that the AV node causes the contraction, and then between contractions, the AV node can't contract again, okay? So this is known as the refractory period. So contraction, and then relaxation, then contraction, then relaxation, right? And so that relaxation portion, that's what controls the heart rate, okay? So the ventricular contraction rate in this case would be controlled by the AV node refractory period, okay? Now, the atrial muscle depolarization rate has nothing to do with the ventricular contraction rate, okay? They're two different things. Just because the atrium's contracting doesn't mean the ventricle has to contract. So in this case, it's because the SA node isn't working, it goes to the AV node, and the AV node can't, obviously, it doesn't continuously contract. So in this case, the refractory period between the contractions is what's determining the ventricular contraction rate. I hope that makes sense. If it doesn't make sense, I can try explaining it again. Okay.
It do make sense, but I have a question.
Yeah.
So if there's atrial contraction that's not generated from the SA node, will that be present as a B wave or an abnormal B wave, like inverted or
So
large?
in terms of like it being a P wave or it not being a P wave, from what I like remember is that the actual atrium contracting does cause a P wave, but what can happen is that the P wave can get stuck inside the QRS complex, so you don't actually see it on the ECG. Does that make sense?
Yeah, it makes sense. Thank you.
Next question. Okay. A 21-year-old man comes to the office due to recurrent heart palpitations that start and stop abruptly. After initial workup, the physician suspects that there's abnormal conduction pathway in this patient's heart that bypasses the AV node. Assuming the diagnosis is correct, which part of the patient's ECG is most likely affected during the normal sinus rhythm? Okay, now you guys are saying B. What do you think the disease is here? What do you think is causing this abnormal conduction path, or what do you think is the result of this abnormal conduction pathway? Correct. It's Wolff-Parkinson-White. Okay. So the answer here would be B. Does anyone know what the sign is called? Or what the wave is called, I guess. Perfect. Delta wave. Okay. It's a fairly simple concept. Basically, an accessory pathway is made here between the atrium and the ventricle, so it bypasses the AV node, which means that the ventricle contracts a little bit earlier than it normally does, and that's what causes this kind of wave over here. Okay, now this pathway is called bundle of Kent. Not as high yield for you guys, but I thought it was important anyways, because sometimes these clinical doctors, they like to bring stuff that just in the corner of one slide, and they'll bring it anyways. Any questions about this? Okay, let's move on. Okay, I'll just go through it. 68-year-old man has worsening dyspnea and orthopnea for the past 3 years, with increased production of frothy white sputum. Okay. On examination, crackles are auscultated at the lung bases, and chest radiograph shows bilateral interstitial infiltrates, distinct curly B lines, and a prominent left heart border. They give you a bunch of labs here, which I'm not gonna go through. But what I want you to think about is that, look, this question, obviously this is a cardio question review, so it's not that difficult to figure out what the answer is here. But the reason I put this question is because I want you to kind of see, yeah, it is C. I want you to see how do they ask, what things do they put in the question to kind of put you towards congestive heart failure, because they can kind of play with it, but if they put these specific words, if they put orthopnea, if they put orthopnea, which is, why am I hearing myself? If they put orthopnea, which is if you're lying supine, like you have shortness of breath, or if they put crackles, or they put curly B lines, or BNP, these types of things can kind of lead you towards heart failure, right? Yeah, exactly. So the thing is with BNP specifically is that it's not necessarily indicative of heart failure. But what it does do is that if BNP is low, then that tells you that it's not heart failure. Okay, so it's called negative predictive value. So if all signs point to heart failure and BNP is high, then it guarantees it's most likely heart failure. But if BNP is low, that means it's not heart failure. Can't be heart failure. Okay. In this question, obviously it's C. There's no other answer choice here that even makes sense. Now just some basics on heart failure. Most likely caused by coronary artery disease, hypertension, diabetes, smoking, obesity, alcohol consumption. These are all risk factors. And this is what's, in my opinion, more important for you guys to look at, which is the clinical features: dyspnea, orthopnea, pulmonary edema, jugular venous distension, hepatomegaly. This is more for like right-sided heart failures, pitting edema, fatigue, rales, and crackles. Okay. Again, heart failure is not that difficult of a topic. It's kind of simple, but it's easy to figure out, especially when you know what to look for. Okay. We'll move on to the next question. I think it's faster if I just read it. Okay. Now, a 41-year-old man comes to the emergency department with 3 days of fever, chills, and non-productive cough. Patient also felt tired and weak during this period. He has a history of injected drug use and has been hospitalized several times for injection site cellulitis. Temperature is 38.3, blood pressure is 125/72, and pulse is 112 and regular. Okay. Cardiopulmonary auscultation reveals scattered rhonchi and cardiac murmur, which were not previously present. Laboratory evaluation shows leukocytosis, and a chest X-ray reveals nodular opacities. Echocardiography of this patient is most likely to reveal which of the following findings. Okay. What do you think the answer is here? F. Why do we say F? What is the disease here? Infective endocarditis. Okay. And what bacteria is most likely causing this one?
Is it S. aureus?
Yes, Staph aureus. Infective endocarditis is a fairly large topic, but it can be divided very, very simply into acute, subacute. Acute, which is what we see here, 3 days, most of the time is due to Staph aureus. Okay. And what happens is that most of the time in the questions is they'll tell you that the guy has, IV drug use, history of IV drug use. Most commonly it affects the tricuspid valve. So if you see tricuspid valve in the question, or if you see Staph aureus in the question, you can kind of make that connection. It's very easy to make that connection. As opposed to acute, subacute, which is instead of a few days, they'll tell you, oh, patient came for after a few weeks, maybe 2-3 weeks. Okay. It's seen on abnormal or diseased valves. And more importantly, which is what you'll see in a lot of your questions, is that it's after dental procedures. Okay. So we'll say, oh, like 2-3 weeks ago, patient had a dental procedure. Now he's coming in with these symptoms. Okay. In subacute or strep viridans, The mitral valve is the one that's most commonly affected, but it can affect the aortic valve as well. Okay. Now some other things that they like to bring from micro is prosthetic valve is associated with strep epidermidis. GI procedures associated with enterococcus, and then the one that came in our exam is colon cancer with strep bovis, or if she's being updated, then the galolyticus. Gram negative is the Hastic organisms. Not as high yield, but definitely good to go over. Also important to note, non-bacterial thrombotic endocarditis associated with adenocarcinoma. This comes on the exam as well. And Liebman Sachs is associated with SLE. And then the vegetations, because he has these pictures in your lectures, and he brings the exact same pictures in the exam. Okay, and so he'll have the picture, and it'll show vegetations on this side of the leaflet and on this side of the leaflet, and immediately you know it's Liebman Sachs. That's one thing about Abdulkader, by the way. If you memorize his pictures, like any picture that comes on the exam will be from his slides. So it's very easy to get those questions right because it's the same pictures. And so if you see that picture and you remember it from the lecture, immediately you know, okay, this is Liebman Sachs. I don't even have to read the question. Immediately from the picture alone, I know this is Liebman Sachs. Even in OSPE, if he brings any pictures, most 99% of the time it'll be from the lectures. Every so often they do bring like random pictures, but most of the time it's from the lectures. So I would definitely go over them. Additionally, important part that I didn't put last year that I'm going to put this year is that the major and minor criteria, blood culture, major criteria, echo, major criteria, and then there's a few minor criteria, but more often than not, they ask you which of the following is the major criteria. And I believe most of the time the answer will be blood culture, but echo is also major criteria. So this is important to know this because when you go over like a topic, you kind of have to think about how can they ask us in the question, right? And so for this, it's very easy. They can give it how they gave it in this question, where they want to ask, is it Staph aureus? Is it tricuspid? What is the risk factor? Is it IVD or is it dental procedures? Or they could ask about the criteria, right? Which of the following is a major criteria? So that's a question that comes pretty often. If anyone, these are also like some of the other signs that you can look for. If you see any of these signs, then that also tells you that it's infective endocarditis. Does anyone have any questions about this? Clear, perfect. One more thing that I want to mention, in terms of like steps and stuff like that, they don't always tell you strep viridans. Sometimes they'll tell you they call it strep mutans. I don't know why. They just like to trick you. But if you see strep mutans, that's also strep viridans. It's the same thing, just in case. Where's the question? Well, you know what this question's about now. 7-year-old boy is brought to the physician because of a 5-day history of fever, malaise, and joint pain. Okay. He had a sore throat 4 weeks ago that resolved without treatment. Temperature 38.6, blood pressure 84/62. Physical exam shows several firm, painless nodules under the skin near his elbows and the dorsal aspect of both wrists. Cardiopulmonary examination shows bilateral basilar crackles and blowing hollow systolic murmur heard best at the cardiac apex. Both knee joints are warm. Laboratory studies show an ESR of 129. The immune response seen in this patient is most likely due to presence of which of the following? So what do we think that it is? E, perfect. M protein, molecular mimicry. I feel like it's fairly straightforward. But just to go over it just again, rheumatic fever associated with group A strep. In this case, it was molecular mimicry to the M protein, right? Mitral valve is the one that's most commonly affected. It causes regurgitation. However, if it's chronic, if it keeps happening, then it can cause stenosis. But most commonly, they're going to ask you about the regurgitation aspect. If it affects the aortic valve, it can cause fusion, which is, I believe, the fish mouth appearance. And then here I mentioned the stenosis. It can also predispose to subacute endocarditis. On labs, oftentimes you'll see anti-strepsin, ASO, I think it's anti-streptolysin antibodies and anti-DNase titers. These are just things that they can ask about in the question. They can ask which of the following can we see on labs. And then these are the different signs and symptoms you can see. You can see joint pain, you can see carditis, nodules, you can see erythema marginatum or Siddons chorea, which is like rapid movements of like the hand, which we don't see in this patient, but we see most of these in this patient. Anyone have any questions about this? I feel like rheumatic fever, pretty simple. Great. Okay. A 32-year-old man comes to the emergency department with chest pain that started earlier in the day. The pain is midline and sharp and increases with deep breaths, but decreases when the patient leans forward. He had a mild respiratory illness a week ago. Other medical history is unremarkable. The patient is a lifetime non-smoker and has no family history of early onset heart attack, sudden death, or cardiomyopathy. Blood pressure is 120/70, pulse is 110, and regular. Which of the following physical examination findings is most expected in this patient? Okay. Answer here is A. What is the disease?
Pericarditis.
Pericarditis, yes. Now, what is something in the question stem that kind of tells you that it's pericarditis? Yeah. So in pericarditis, they have pain with like inhalation, but when they move or when they change positioning, the pain decreases. So that's something that you have to look out for in questions. So if you see decreases with movement, specifically here, decreases when leaning forward, that tells you, that kind of leads you towards pericarditis. Now, sometimes they'll put friction rub in the question stem and they'll ask you what's the diagnosis, but this one is a bit more tricky. So friction rub is a sign of pericarditis. Pericarditis is inflammation of the pericardium. Most commonly, it's fibrinous to serifibrinous. Like I said, aggravated by inspiration, relieved by movement. The reason why it's relieved is because it decreases pressure on the pericardium, and that's why that pressure is what's causing the pain, because the heart itself isn't innervated by any sensory nerves, so that pressure on the parietal pericardium, that's what's causing the pain. The friction rub can be heard in auscultation. That's kind of that almost pathognomonic for pericarditis. Some important causes. The most common cause is idiopathic. After that, other causes it could be viral, most commonly by Coxsackie B. It could be bacterial. It could be uremia, CT, etc., etc. It could be post MI. There are two different types of pericarditis post MI, which one is the fibrinous pericarditis, and the other one is autoimmune pericarditis, which I don't think is as important, but it's just a good information to know. Additionally, radiation or malignancy could also cause pericarditis. Anyone? What about D? Okay. D, pulsus paradoxus. Now, does anyone know what pulsus paradoxus is? I think I had a slide on this. I think I removed it. Wait. Let me see if I can find. Yeah, okay. So pulsus paradoxus is actually associated with cardiac tamponade, not with pericarditis. So cardiac tamponade has, does anyone know what Beck's triad is? Yeah, so Beck's triad, hypotension, distant heart sounds, and distended neck veins. Now this Beck's triad is basically tells you that it's cardiac tamponade, but one of the other findings that you'll see is pulsus paradoxus, which someone in the chat mentioned, is when the blood pressure during inspiration drops, right? And that's not nothing to do with pericarditis. So that's why it wouldn't be the right answer here. Does that make sense? Yep. Okay. A 60-year-old woman has reported increasing fatigue over the past year. Laboratory studies show a serum creatinine of 4.7, urine nitrogen of 44. An abdominal ultrasound scan shows that her kidneys are symmetrically smaller than normal. The high magnification microscopic appearance of the kidney is shown in the figure. These findings are most likely to indicate which of the following underlying conditions. Yes, answer here is B. What is the disease? Hyaline. Correct. Very important not to get this confused with hyperplastic because they're kind of similar. So these are from your lecture. The one on the left is hyaline, the one on the right is hyperplastic. You can see the onion skinning appearance here. The way I like to think about it is hyperplastic kind of sounds like like cancerous almost. So I kind of think of hyperplastic is always severe. So it's caused by severe malignant hypertension, and it can cause acute renal failure. Okay. Hyaline is caused by essential hypertension or diabetes. Now it can also lead to renal failure, but just in my head to kind of separate the two, I kind of think it as not as bad. Whether or not that's actually true, I'm not really sure, but that's just the easy way for me to like classify them. Make sure you memorize these pictures because like they'll bring this exact picture and they'll say, what is this? Or they can bring some of the other ones from this lecture. I believe, Monkeyborg or whatever. They can bring whatever they like abroad brings like a picture from the lecture and he'll ask, what is this or what is it caused by? So it's very important to know these pictures. Just like this question, like nothing from the question alone would have told you what it is except for the picture. Like the most important part of this question was the picture. So make sure you know the pictures. Any questions about this? No, perfect. Okay. A 30-year-old woman has had coldness and numbness in her arms and decreased vision in the right eye for the past 5 months. Physical exam, she is afebrile. Her blood pressure is 100/70. Radial pulses are not palpable, but femoral pulses are strong. She has decreased sensation and cyanosis in her arms, but no warmth or swelling. Okay. A chest radiograph shows a prominent border on the right side of the heart and prominence of the pulmonary arteries. Lab studies show serum glucose 74, creatinine of 1, cholesterol 165, negative ANA. Her condition remains stable for the next year. Which of the following is the most likely diagnosis? You're already answering it. Okay, easy. D. Now what makes us say D? Why did we choose D here?
One of the signs is the decrease of the vision, so it affects the ophthalmic artery.
Okay. Why else though? Yeah. So people were saying in the chat. So the fact that the pulses are not palpable, right? Especially the upper pulses are not palpable, and also just being a young woman are signs like these are signs like so a young woman, especially young Asian woman with it's called pulseless disease, I believe, right? So a young Asian woman who you can't feel the pulses in the upper extremities, oftentimes that's Takayasu. In general, when it comes to the vasculitides, there's quite a few of them. It's easy to get confused between them. So the graph from your lecture, I like it. I like it a lot. So what I like to do is, because in my opinion, it's not totally encompassing. So, but to organize them into large, medium, small kind of helps to remember, okay, which is which. So what I'm gonna do is I'll just go through each one and I'll tell you some like extra information that you might want to know about them. Okay. Uh, for giant cell arteritis, maybe you guys can tell me what else is seen with giant cell arteritis. What is another important finding? Blindness. In addition to blindness, we can get headaches, we can get granulomas. That's also important. Takayasu, we said young Asian woman. Additionally, we also see granulomas. Oftentimes it's the narrowing of the aortic arch or the great vessels, the proximal great vessels. So sometimes they'll give you like an angiography or aortography, and they'll show you like a narrowing near the aorta. And so if you see a young Asian woman and you see that narrowing, then immediately your mind should go towards Takayasu. Polyarteritis nodosa. The way I think about it is it affects almost everything except for the lungs. It's associated with Hep B. It is associated with renal microaneurysms and fibrinoid necrosis. Kawasaki, seen in young Asian kids. Probably not as high yield for you guys. But one interesting fact that I found out was that Kawasaki is the only time that you give aspirin to kids. Why don't you normally give aspirin to kids? Let's see who remembers there. POD. So the reason why you don't give aspirin to kids is because they can cause Ray syndrome. Okay. Yes, exactly. So the Kawasaki is the only disease that is an indication for aspirin in kids. And moving on, GPA, otherwise known as Wegener's granulomatosis. The way I think of it is the way that the pathoma doctor teaches it, which is to think of it as like a C disease. Okay, it has C ANCA. It affects the body like it's a C, which is like nasopharynx, lungs, and kidneys. It kind of makes a C with your body, and also what's it called? The name used to be Wegener's, so you kind of changed the G to a C. Wegener's granulomatosis. They changed it because they found out he was like a Nazi or something, but now it's GPA, but you can still kind of think of it as Wegener's granulomatosis to kind of help with the C. In the name is granuloma, so it has granulomas, has necrotizing granulomas. It comes to Church-Strauss. Anytime you see eosinophils, atopic dermatitis, asthma, anything to do with IgE type thing, your first thought should be Church-Strauss. It also has granulomas, and the reason why I'm mentioning all these granulomas is because microscopic polyangiitis is very similar to GPA. It's very similar to some of the other diseases, except there's no granulomas. In addition to no granulomas, it's P ANCA, similar to Church-Strauss. So these two, P ANCA, this one C ANCA, right? This one, MPA, has no granulomas. These two have granulomas, right? Additionally, this one, GPA, affects, like I said, it's a C, so affects the nasopharynx. So you can get, sinusitis, you can get like symptoms up here. But MPA, you get no symptoms, no sinusitis symptoms, no nasopharyngeal involvement, just the lungs and the kidneys. So that's like kind of a way to differentiate the different types, because I know that it's like a lot of names, so it can get kind of confusing. But if you focus on what's different between them, it's very easy to categorize them in your mind. I hope that kind of made sense. If it didn't, I can go over it again. Made sense? Perfect. Okay, let's move on then. A 50-year-old man comes to the physician because of swelling of his legs for 2 months. 3 months ago, he was diagnosed with hypertension and started on a new medication. His blood pressure is 145/95. Physical exam shows 2+ edema in both lower extremities. Lab studies are within reference ranges. The patient was most likely treated with which of the following drugs? Okay, yeah. Answer here is E. So in general, I mean, you guys probably know this because you finished second years, right? But when it comes to pharma questions, there's only so many things they can ask, right? They can ask the method of action, they can ask for what it causes, like what it treats, sorry, or they can ask for adverse effects or like contraindications. So in this case, the dihydropyridine calcium channel blockers, one of their main side effects is that it causes lower limb edema. So that's an important side effect to note, because oftentimes what will happen is that the doctor will prescribe them this drug, they'll have the edema, they'll come complaining of the edema, and then the doctor will prescribe them a non-dihydropyridine CCB, because those affect the heart, right? And dihydropyridine affects the vessels. That's why it causes edema. So instead of amlodipine, they'll give them like diltiazem or something like that. And so that way they won't have the edema anymore, but they're still having the same, beneficial effects. Does that make sense? All good for this question? Yeah. Remember, guys, side effects, very important. Okay. This is in my opinion, the most important concept in cardio. It gets tested very heavily. 2 days after being admitted for acute MI, 61-year-old man has sharp substernal chest pain that worsens with inspiration and improves when leaning forward. Cardiac exam shows a scratchy sound best heard over the left sternal border. Histopathological examination of the affected tissue is most likely to show which of the following findings. Okay, first of all, immediately we know that this is pericarditis, but that's not really that important for this question, even though it should help you get to the right answer. What is the right answer here? Okay, I need you guys to be more confident in your answers. Yeah, so the answer here is A, neutrophilic infiltration. So this concept is very, very, very important. And it's basically the histological changings after MI. You have to know, one, what are the changes? Two, when do they happen? And three, what do they look like histologically? Okay, because what will happen is they'll bring a clinical vision and they'll say, okay, 7 days after MI, which of the following cells will you find here? Or what complication will you have here? So the way I like to go about this is very similar to the way in the lecture, but I follow again. I like me personally. I love the way Pathoma explains it, and if you have the time, I'd suggest going over the Pathoma lecture because he does a very good job explaining. So this table is from Pathoma. The next slide is from your lecture. So I'm gonna go over this table first, and then I'll kind of go over the table from your slide from your lecture as well to kind of compare them because they're essentially the same. Okay. Now the way that Pathoma explains it is that you want to separate it into 1 day, 1 week, 1 month. Okay. Now in the first day, you get coagulative necrosis. That's within the first 24 hours. Okay. And that's what gives you that dark discoloration. Coagulative necrosis, dark black. That's what you want to think about. Okay. What you're scared about in the first day is arrhythmia, specifically VFib. Okay. That's the thing you're most scared about after MI is VFib because that leads to death. Okay. Very important. I'll like 99% chance to get asked about this. Okay. After the first day, we move on to the first week. So we go from coagulative necrosis to the first week now is inflammation. Okay. So first day is coagulative necrosis. First week is inflammation. Now inflammation starts with neutrophils and moves on to macrophages. Okay. So meaning beginning of the first week is where you see neutrophils. So from the days might be a little bit different, but let's just say from 1 to 3 days is neutrophils, and from 4 to 7 days is macrophages. Now the neutrophils are what will give you that yellowish color, okay? And what can happen is, especially in transmural infarcts, is that the neutrophils can kind of leak into the pericardium. It can cause fibrinous pericarditis, and that presents as friction rub, right? And so that's what our patient has here, okay? So he has substernal chest pain, worsens with inspiration, improves in leaning forward. This is pericarditis. And like I just said, the pericarditis is caused by neutrophils. So even if you don't know the timings, you can figure this out based on the fact that neutrophils are what cause the pericarditis. But I think it's more important that you know the timings. Okay, so this was the first 2 days, so that's why we said neutrophils. Macrophages, they come after neutrophils because they eat up the debris, okay, the stuff that's left behind, the stuff that's dead and necrotic. And so what happens is that when it eats up this stuff, it weakens the walls. All the walls of the heart become weakened. The septum becomes weakened. The ventricular wall becomes weakened. Every single wall of the heart gets weakened. And so the word that you're looking for is rupture, because what happens is that when it weakens, it's prone to tear apart. Okay, so the ventricular wall can rupture, the intraventricular septum can rupture, the papillary muscle can rupture. So the later half of the first week, macrophages can lead to rupture. Okay, now after the first week, we can get to the first month, which is when we kind of start to get the scar formation. Okay, and now scar formation starts with granulation tissue. So after 1 week is when we start to get that granulation tissue. What happens is that the granulation tissue comes from outside. It doesn't come from inside, it comes from outside. So the granulation tissue, the new blood vessels and stuff comes from outside. That's why you get a red border. Okay? So you get a red border because the granulation tissue is coming from outside. And then afterwards, it'll take months, months and months. Eventually you get fibrosis, which comes as a white scar. And once you have fibrosis, that's when you start to think about aneurysm because the wall's weak, right? Or thrombus, or this Dressler syndrome is what I mentioned earlier, is autoimmune pericarditis, which I don't think is that important for you guys. Now, if we're going over the table from your lecture, we'll just go over the same things that we talked about, okay? So within the first day, okay, here it says 4 to 12 hours, coagulation necrosis, exactly what we talked about. Dark mottling. Necrosis is what causes that dark mottling, okay? 24 hours is still within the first day. Again, we're talking about coagulation necrosis, dark mottling, okay? Here, they say beginning of the neutrophilic infiltrate. So, but this is towards the end of the first day, okay? So between 1 day and 1 week, so the 1 week period, it begins with neutrophils. So 1 to 3 days, yellow tan, interstitial infiltrate of neutrophils, okay? Coagulation necrosis will obviously still be there because, it started within the first day, okay? Second half of the week, 3 to 7 days, we mentioned phagocytosis by macrophages, okay? Here we kind of start to see the hyperemic border, but like mostly what you see is the yellow tan, okay? Exactly the same as the pathoma table, okay? Then after the first week, that's where we start to see granulation tissue, okay? This is when we start to see the red tan margins after the first week, okay? Then after, within weeks to months, this is when we start to see the collagenous scar, okay? Here it says 10 to 14 days is when you kind of see the well-established granulation tissue. So if there's any differences between the two tables, focus on what's written in this table because obviously abroad is writing your questions. But this should kind of give you the concepts, the foundation on how you want to think about these questions because very important. And if you think about it like this, it becomes very easy. 1 day coagulative necrosis, 1 week inflammation starts with neutrophils, progresses to macrophages, and then 1 month is the scar tissue. Does that make sense? Or should I go over it again? Perfect. Okay. Now let's move on. An investigator studying effects on drugs and cardiac action potential, cardiomyocytes are infused with a pharmacological agent and incubated for 5 minutes, after which action potential is registered on the graph in real time. Black line represents an action potential following infusion. Okay, essentially, forget all the stuff that's written here. What it's asking you is, it gives you this graph. It's asking what the agent, basically the drug, this is talking about antiarrhythmics, inhibits which of the following. Okay? What do we think the answer is here? Okay, yeah. Answer here is D. Voltage-gated sodium channels. What is the drug? Not necessarily what is the class? Class 1. Exactly. Okay. Perfect. Specifically class 1C. Okay. When it comes to antiarrhythmics, it's important to know the graphs, because they can just bring you just straight up, they'll bring you the graph and they'll say, okay, what class is this? So if you can just memorize the graphs, or even better, if you can understand the graphs, it'll really help you. I recommend, if you want to understand these drugs very well, the Boards and Beyond video is very long, but in my opinion, it's very good. And if you have the time, it's worth watching. If you don't have the time, then you can just, try to memorize. But how you want to think about it, how I think about it is that this is the QRS, right? And this is related to the potassium here, okay? So this right here on the left, this is myocardium, and this is the sinoatrial, okay? So we have 4 classes, right? 1, 2, 3, 4. Class 2 and 4 affect the sinoatrium, okay? Class 1 and 3 affect mostly the myocardium, okay? So if something affects the potassium, then it could increase the QRS interval, okay? It can increase the AP diameter. something affects, sorry, not the potassium, sorry. Something affects the sodium. If it affects the potassium, then it can increase the QT interval, okay? So let me repeat that because I kind of messed that up. If something affects the sodium, it'll lead to this graph kind of going like this, right? Like what we saw here. That can lead to QRS prolongation. If something affects the potassium, it can lead to QT prolongation, okay? Now, if we look at that here, these are just the graphs of each one, right? Class 1A has both sodium and potassium, right? That's why you kind of see it like this. I suggest going over these, memorizing all of them if you can. I personally suggest, as I said earlier, to go over the Boards and Beyond video for it because he explains it very well. But it is long, and I don't know when your exam is exactly, but I know it's coming up soon. So definitely try to learn it, but if you have other priorities, go over them first. And just some tidbits about each one. Class 1A, quinidine, procainamide, they block the sodium channels, right? Which is why this was the answer over here to our question. Okay, block the opening of the sodium channels. Some important side effects, specifically drug-induced SLE with procainamide, and QT prolongation. What is the complication of QT prolongation? Yes, torsade de points. Exactly. In drug-induced SLE, you'll see antihistone antibodies. That's probably not important for you right now, but it'll become important when you do the MSI block. 1B lidocaine. So that's the most important one, but this one's not asked as much as 1A and 1C. Flecainamide can completely block the action potential. Not used as often. It's a last resort drug. We can move on to beta blockers. As I said, class 2 and class 4, these are the ones that affect the nodes. It's nodal action potential. So they're more used in like AFib or supraventricular tachycardias. Class 3, this is the most high yield in my opinion out of all of them. Specifically amiodarone because it has a bunch of side effects. But it has class 1, 2, 4, it has effects, all types of effects, right? So it's used in all types of arrhythmias. But it has a bunch of side effects that you need to know. These are very important, very, 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 very important. Okay. Sotalol is actually a beta blocker, so it's class 2 and class 3. But like I said, class 3 most important. Okay. That being said, don't take that as a only learn class 3. Make sure you know all of them. Specifically the graphs. Try to learn the graphs if you can, because these are important, and I think these are what get asked more specifically in your exams. Okay. Any questions about this? Clear. Okay, perfect. Now, this question. In that question, why isn't it closing of the? Because the question here is asking it's asking which of the following is inhibited. Okay. So what's inhibited is the opening of the sodium channels. The closure of the sodium channels is not being inhibited. Does that make sense? Specifically, like you have to look at what the question's asking here. It's not asking what's being done. It's asking what's being inhibited. So that specific word, that's why it's what being inhibited is the opening. Okay. Oh, sorry. Let me go back. Okay. An otherwise healthy 27-year-old woman is referred to a cardiologist because of a murmur detected by her GP during a routine health maintenance examination. She has a history of recurrent episodes of sore throat and fever during childhood. She immigrated from Kenya 6 years ago. Cardiac exam shows an opening snap followed by a late diastolic rumble, which is best heard at the 5th intercostal space in the left mid-clavicular line. For the following, pressure volume loops is most likely to correspond with the patient's cardiac. Yes, okay. Now, this is almost a guaranteed question. Okay? These pressure, flow, whatever volume loops are very easy to ask, and they kind of test like what you know, okay? Now I want you. What is A?
Aortic stenosis.
Okay. A is aortic stenosis. B. Okay. B is mitral regurgitation and C is aortic regurgitation. The way I kind of think about it is that now this might not be like the exact physiological mechanism behind it, but I just look at the fact that this one is substantially bigger. And so in my mind, the aorta is bigger than the, you know, than the atrium. So like the mitral stenosis, aortic stenosis. So in my mind, the one that's bigger would be aortic. The one that's, if it's smaller, it'll be mitral. But the way you can also think about it is if you see this over here, increased preload, more likely to be mitral. Not stenosis, sorry, regurgitation. D, as you guys said, the answer is mitral stenosis. And then E, not important for you guys, but it's ventricular systolic failure. Okay. Again, know these. I think that in your exam it might even be color coded as like red and green, but just in case it's not, definitely know the graphs. Because like I said, almost guaranteed to come. And it's not that difficult. It's not, you only need to know like 4 of them. Any questions? Wait, let me go. Okay. So when it comes to murmurs in general, know the keywords: crescendo, decrescendo, holosystolic, low, late systolic, mid-systolic click. You need to know these keywords because it'll kind of give you a hint. If you also know where it is, is it, second intercostal, right side, left side. If you know where it is, it'll help you as well. But I think knowing these keywords will help you the most because immediately if you see crescendo, decrescendo, you're thinking stenosis, right? If you see opening snap with diastolic rumble, immediately mitral stenosis. Early diastolic decrescendo, immediately aortic regurgitation. And also you got to think about, okay, in diastole or in systole, where is the blood going, right? And in diastole, the blood is going, from the atrium into the ventricle. So when the blood is going this way, what types of things could possibly make a murmur there, right? If the blood is going from the atrium to the ventricle, then it could be stenosis of the mitral valve, right? Or it could be regurgitation of the aortic valve because that's the blood's going this way, right? Or if it's systolic, then the blood's going through the aortic or pulmonic valve, meaning it could either be aortic or pulmonic stenosis, or it could be mitral regurgitation. So if you can just think about where the blood is going through each of the different phases, it'll kind of help you think about, okay, what type of pathology is it? I think that's it for this one. Any questions on this? This, in case anyone was wondering, this stands for syncope, angina, and dyspnea, which is classical clinical presentation associated with aortic stenosis. I just want to point out, as I mentioned earlier, so this patient, she had recurrent rheumatic fever. And I said rheumatic fever, it becomes mitral regurg, but if it's recurrent, happens over and over and over and over again, it can become mitral stenosis. So that's why this patient has mitral stenosis. Okay. 14-year-old boy comes to the physician for follow-up after a blood test showed serum triglyceride level of 821. Several of his family members have familial hypotriglyceridemia. The patient is prescribed a drug that increases his risk of gallstone disease. The expected beneficial effect of this drug is most likely due to which of the following actions? I'll read it carefully. First, can someone tell me what drug they're talking about here? Okay. Um. So were you guys given a lecture on statins and fibrates, and were you guys given a lecture on this?
Yeah, we took.
Okay. Okay. So the answer here is actually A. Now, does anyone know? So the drug here that they're talking about is fibrates. The way that you can think about fibrates is that here it's saying increases risk of gallstone disease. One of the classic side effects of fibrates is that it decreases the bile acid and increases the concentration of bile, so it can lead to cholecystitis or any gallstone disease, right? When it comes to the other answers that you guys gave, I believe what you guys say B. So the B is what is B? Anyone know what B is? Yeah, PCSK9. So these are not associated with any gallstone or gallbladder diseases. Neither is F. Now some people, I think last year they said D, and the reason D is wrong is because fibrates' method of action is to activate PPAR alpha, not PPAR gamma. So PPAR gamma is a different drug altogether. It's a anti-diabetic drug. So that's why I didn't want you guys to get confused. But the answer here would be A, because what it ends up doing is it ends up activating lipoprotein lipase. Now I'm thinking right now that maybe, I'm not sure, maybe you weren't taught this in the lecture. If you weren't, then that's fine. We can move on. Okay. Okay. 16-year-old boy is brought to the emergency department 20 minutes after collapsing while playing basketball. There's no personal or family history of serious illness. On arrival, there's no palpable pulse and no respiratory effort is being seen. He's declared dead. The family agrees to an autopsy. Which of the following is most likely to be found? Now, I don't want you to give me one of these answers. I want you to tell me what the disease is here. What did this 16-year-old boy have?
Maybe corruption of the aorta.
No. So yes, so this patient, 16-year-old boy who collapsed while playing basketball and died, had hypertrophic cardiomyopathy. This is a classic scenario. Now the answer here is E. That's not really high yield for your exams, but high yield if you want to do any other like bigger exams. It's important to note that this scenario is very classic. A patient coming in, he's playing some sport, young patient, and he suddenly dies. Okay, and sometimes they'll give you a picture of the heart and you'll see that it's hypertrophic, but sometimes they won't do that. Most common cause of hypertrophic is genetic. Okay, these are the two genes that are high yield to know: myosin binding protein C and beta myosin heavy chain. It is diastolic dysfunction, and what you see is concentric hypertrophy. Now, what does concentric hypertrophy mean? It means that the sarcomeres get added in parallel, which means they get added like this. Okay, they get added one after another like this, and the actual ventricle becomes a bit smaller because of it, right? Very commonly seen in young athletes, and it causes sudden cardiac death, which is what happened in our patient. Now, if we were to compare this to dilated cardiomyopathy, that is a systolic dysfunction, and it causes eccentric hypertrophy. Eccentric hypertrophy means that the sarcomeres get added in series, which means like this. It means the chamber gets bigger, and this is like, think of this as the ventricle, right? So they get added one after another, and the chamber gets bigger, and so it becomes a systolic problem because it can't push out the blood. Okay. Now, the most common cause of dilated is idiopathic, but it can be genetic. And it's important to know these genes because I've seen it asked, and I distinctly remember in class Dr. Abrar telling us that he does ask. It didn't come on our exam, but I think came in the last batch's exam, where they'll tell you patient with dilated cardiomyopathy, which of the following genes is affected, and they'll give you like 3 of the hypertrophic and 1 of the dilated, and they want you to choose the dilated, right? This one is the most commonly asked, dystrophin. They might ask about titin as well, but dystrophin, if you see dystrophin as the answer for dilated cardiomyopathy, I would choose that as the answer. Alternatively, it could be due to drugs. Specifically, doxorubicin is a high yield cause. Kawasaki B virus. It could be due to ischemia. systemic conditions such as thyrotoxicosis, and peripartum, which means postpartum, like during pregnancy. Also, a restrictive is another type of cardiomyopathy, which doesn't get talked about as much, but it's also important. The way I think about it is through osis. So if you see any osis at the end, then immediately my thought goes towards restrictive, sarcoidosis, amyloidosis. It's important to know the different things you see. I believe apple green bifringence, whatnot. That type of stuff is important because they like to ask about that type of stuff. But yeah, in terms of the septal hypertrophy, not as important for your exam. If it comes, then good for you. But important later on, it'll be important. But what you should know is if you see a young kid, he was doing something athletic, he was playing basketball, and then suddenly he died, immediately your mind should go towards hypertrophic cardiomyopathy. Even if there's no thing in history, they said there's no personal family history, that's fine. It doesn't have to be. Okay. Any questions about this? And someone said coarctation of the aorta. For coarctation of the aorta, the patient will present to the ER and you'll present with like tearing pain that radiates to the back. Okay. Any questions? Okay. A 65-year-old woman comes to the physician because of a 3-month history of progressive shortness of breath and dry cough. She has also noticed gradual development of facial discoloration. She has CAD, hypertension, and AFib. She does not remember which medication she takes. Her temperature is 37, pulse is 90, respiration is 18, blood pressure is 150. 150 over 85. Pulse oximetry on room air shows oxygen saturation of 95. Examination shows blue-gray discoloration of the face and both hands. Diffuse inspiratory crackles are heard. An X-ray of the chest shows reticular opacities around the lung periphery and particularly around the lung bases. Most likely cause of the patient findings is adverse effect towards the following medications. So you guys are already saying it. It is F, amiodarone. What gives away that it's amiodarone? Blue-gray discoloration, this reticular opacities, lung periphery. So we said that amiodarone has a lot of adverse effects, right? So included in those effects is this, blue man syndrome, blue-gray deposits. Additionally, pulmonary fibrosis, which we saw in this question stem. Hepatotoxicity, they'll show like elevated liver enzymes, hypothyroidism or hyperthyroidism because amiodarone has 40% iodine. So it can either cause hypo or hyper. It can cause either one. It doesn't matter, right? And then, like we said, it could also cause some cardiovascular events. We said QT prolongation. But this is important. Sometimes they bring a picture, just straight up. They'll bring, blue man syndrome. If you see this picture immediately, you should know amiodarone, class 3, blocks potassium channels, because those are the different ways they can ask it. They can ask, what's the drug? What's the method of action? What class is it? Adverse effects. Okay. Any questions? Okay, good. Okay. A 61-year-old man is brought to the emergency department by ambulance because of severe retrosternal chest pain and shortness of breath for 30 minutes. Paramedics report that ECG recorded en route to the hospital showed ST elevation in 1 and AVL in the precordial leads. On arrival, the patient unresponsive to painful stimuli. Examination shows neither respiration nor pulse. Despite appropriate life-saving measures, he dies 10 minutes later. Which of the following is the most likely cause of death? Okay, yeah. So we mentioned this earlier. I put this just to, keep this, make sure, stick it in your mind that VFib is the most important cause of sudden cardiac death post-MI. Okay. I want to, make sure it's stuck. Okay. We have, I believe, one more question. Okay. It's one-liner. Fairly simple. Yeah. Okay. This is a fairly simple concept. Troponin I is most specific, rises for 4 hours, peaks at 24 hours, and is increased for 7 to 10 days. CKMB rises for 48 hours, peaks at 12:24, returns to normal after around 48 hours, right? The reason that that's important is because it's important for the diagnosis of reinfarction, meaning patient had MI, right? Whatever you treat him, whatever. Then, like 12 hours later, he has another MI. How would you know? Or not, let's say not 12 hours, let's say like 3 days later, right? He has another MI. How would you know? If you see CKMB rise again, then you know that, okay, it's another infarction. But the things with the troponin is because elevated for so many days, you wouldn't be able to tell because elevated regardless. This is the one from your lecture. Myoglobin's not as important, in my opinion. The most important ones are troponin I, specifically troponin I and CKMB. That's it for this lecture. If you have any questions, let me know. Feel free to ask. In general, I'm not now. I believe they combined your midterm. They removed your midterm. So now your final is both cardio and pulmonary full. So I don't know how much is going to be cardio, how much pulmonary. In general, it's not that tough of a block. So they all do well. I think that it's pretty interesting. In general, third year is like the pathology is fun, but it becomes hectic because there's like a lot of lectures and stuff, which I understand is important to stay on top of things. Just some advice. Like I said, make sure you go over the pictures, especially pathology. Go over the pictures very well. For cardio specifically, make sure you go over the ECGs. Make sure you know all of them, AFib, atrial flutter, whatever, all of them, because I guarantee you they're coming. I guarantee you. Make sure also for I guess that's it. I mean, for cardio, just like I tried to go over a lot of the main topics. If there's any feedback you want to give or anything like that, please, I believe this QR code should send you to a link where you can give feedback or whatever. And yeah, if you want me to do more sessions, I don't mind. I hope this benefited you guys. And yeah, thank you. If you have any questions, again, you feel free.